Basically, our main goal today is just to promote awareness that concussions are brain injuries. And so it's not a stinger, a dinger, or whatever term you've heard. Oh, he got his bell rung. It's a brain injury. And I think that's one of the most important things that we can tell you guys, and then you can tell your athletes, parents, whoever. And I think people will look at it a little differently versus just he got his bell rung, or she got her bell rung. So we're just going to go over the summary here. So really kind of look at why we care about concussions, what a definition, look at some signs and symptoms. We'll kind of go over specific tools to help recognize and manage concussions, and then basically what are we trying to prevent? Long-term complications or severe brain damage, basically. And so again, it's a brain injury, so let's keep that in mind. All right, so I'm gonna have Darren click on this video. This is 5 minutes long, kind of humbling video here.
2005. LaSalle University in Philadelphia. Plevrides is a 6'2", 230-pound freshman linebacker. At practice, he gets injured in a helmet-to-helmet collision.
I remember him coming home that night, a little bit concussed. You know, you're kind of weary, you don't really know what's going on.
In a game 4 days later, Plevrides tells the LaSalle trainer his head hurts. The trainer sends him to the student health clinic where he is diagnosed with a concussion. But 2 days later, a nurse tells Plevrides he can return to play after sitting out one game.
Was he symptom-free at that time?
No, he was never symptom-free. Not at all.
Why do you say that?
He always complained about headaches.
And how did he deal with it?
Advil, handfuls at a time.
Plevrides plays in 2 games without incident. Then, on November 5th, 2005, with 2:42 left in a game against Duquesne University in Pittsburgh, he tries to make a tackle on a punt return.
He went down like a ton of bricks. I mean, he hit the ground and he was out.
Doctors, trainers, and coaches rush onto the field where Plevrides lay, convulsing.
He was just shaking. And then he kind of rolled over onto his back and he just went completely limp.
I was worried then. I was worried then. You can't describe the look in his eyes.
And I think they're just going to end the game right here. And I think that's a good decision.
It's hard to go play football after you see something like that.
The head coach and team trainer run to Mercy Hospital just a few blocks away. Assistant coach Phil Petit is in the ambulance.
He started to foam a bit at the mouth. At that point, he was starting to fade.
For 2.5 hours, surgeons work furiously to save Plevrides' life. A massive blood clot is putting pressure on his brain. To relieve the pressure, the right side of his skull is removed.
This part was all pushed in because they had taken his skull off, so the brain was exposed. He was on life support.
He was laying there, tubes out of his head. He had tubes going down both nostrils. My beautiful boy was laying there.
Today, 24-year-old Preston Plevrides is the face of concussion and consequence. He struggles to eat, walk, and talk 4.5 years after his injury.
Do you remember the hit that you took on the field?
No. When I
What do you remember about the Duquesne game?
At least 55 high school and college football players have died of brain injuries sustained on the field since 1995, according to the National Center for Catastrophic Sport Injury Research. Preston suffered second impact syndrome, which occurs only in athletes under age 23 whose brains are still forming. It is a rare, often fatal injury that happens when a brain that hasn't healed from a prior concussion is jolted again.
The word concussion in Latin means to shake violently. Think about the brain as an egg yolk inside an eggshell.
Mickey Collins, who has reviewed Plevrides' medical records, is one of the world's leading authorities on sports-related concussions.
If you have a blow to the head, that's sufficient enough to cause the brain to move inside the skull. A certain neurochemical called potassium is released outside of the neuron. At the same time, a second neurochemical, calcium, which is supposed to be outside the cell, it leaks into the neuron. And for some reason, a second blow during this period of metabolic crisis will set off a cascade of events that you can't turn back from. And that's when you see the massive brain swelling. I don't believe the second event would have ended up resulting in a catastrophic outcome if it weren't for the first concussion occurring.
So this is from E60. I don't know if anyone saw that before. But basically, that's kind of what we don't want. We don't want someone to go back to continue to play that's already had a headache, that suffered a concussion in practice, and then they get second impact. And that's really our goal, is to identify who has had a concussion, educate our players, figure out if they're having headaches, they got to let us know. We don't want them to be scared to tell you guys that they have headaches or any sort of symptom, and that way we can prevent any severe complication like this from occurring. Also, here in Oklahoma in 2010, Senate Bill 1700 passed that anyone that has or suspected of suffering from a concussion is not allowed to return to play and should be evaluated immediately by a licensed healthcare provider. And so that's something that not only do we want to keep our kids safe, but it's also the law here in Oklahoma that if you suspect someone having a concussion, get them to see somebody that's a licensed healthcare provider that's been trained in managing concussions. So, on the next one. So what is a concussion? So basically, I'm going to do one other video here, just an animation.
These events can cause the brain to accelerate and decelerate with translational, rotational, and/or angular forces. Brain injuries can result on the side of the force, coup, or on the side opposite the force, contra coup. So what exactly do these forces do to the brain? We believe it leads to a wave of energy that passes through the brain tissue, triggering neuronal dysfunction. This involves a complex cascade of ionic, metabolic, and physiologic events, sometimes called the neurometabolic cascade of concussion. It is believed that this cascade, as well as microscopic axonal dysfunction, cause concussion symptoms. In most cases, this process will generally correct itself, and the majority of patients will fully recover. However, while the brain is still recovering, the reduction in cerebral blood flow may result in cell dysfunction that increases the vulnerability of the cell to a second insult.
The main thing I wanted to show you that it's two impacts. The brain's suspended in fluid inside, an eggshell or our skull. So you got the first initial injury where you got hit from, and then the opposite side where the brain bounces off of it. And that's something that kind of helps us figure out, well, where do they get hit? We can look at mechanism of injuries. Do they get hit on the side versus the back? I've had patients that have hit in the back or fallen on the back of their heads, and then they lose their sense of smell when their sense of smell is all in the front. So it kind of makes sense where the brain got hit in the back, but it's also pulling forward and affecting the frontal lobe and the smelling center. So there's 1.6 to 3 million concussions per year in sports. 75% of concussions do not involve loss of consciousness. Not everyone is just laying there on the ground or that has a big red flag says, hey, I'm concussed, come check me out. It's definitely not as obvious as this guy here. I don't know if you can see that very well with a big, large bump on his head. So that's pretty obvious. Kids don't want to leave the games. They want to win. They don't want to lose. And they're not in the right state of mind to be making those decisions for themselves. They don't know what's best. They're living in the moment, and so they don't want to come out of the game. They're not going to tell you that they have a headache or they don't know where they're at. And so that's what's really important, to rely on our student athletic trainers, our athletic trainers, other coaches and parents to figure out, well, what's going on? Did they fall off a skateboard and hit their head after practice, and now they have a bad headache, but yet you want them to go ahead and do full contact participation. And so that's something that we really have to be in tune with our athletes and really get them to understand how important concussions are. The other thing about concussions is that we used to have a bunch of classifications, whereas it's grade 1, 2, 3, is it simple, complex, and now everyone we treat individually. And that's really important to understand, is that one impact may cause concussion for some person, whereas the same impact may not cause that same concussion in another person. Everybody's different, and there's definitely genetic components to it as well that make people more susceptible. Have people had concussions before, and that makes them more susceptible as well. So the signs and symptoms, are they dazed? They don't know where they're at, they forget plays, they're clumsy. Balance is a good one. Are they really off balance? And that's the way we can use the check on our exam on the sidelines. Memory loss. Do they have memory loss before or after the event? Are they headache? Are they throwing up? Are nauseated? And are they having problems sleeping? A lot of these may not be apparent right after the first injury occurred. I had one patient that we were covering a football game, and he was on the opposite side of the field. Couldn't really tell if he was out of consciousness or anything like that. I ran over and he was awake, says he's doing fine. Bring him on the sidelines, go through our evaluation. We have him run up and down the sidelines. He passes all our memory, concentration tests. He's able to do push-ups. And then we're, all right, well, he had a pretty good hit. We're going to watch him a little bit, but he might, if we'll reassess him again in another 15 minutes, can maybe go back in. So we're getting ready to reassess him. He didn't have a clue where he's at. He's asking him, what's the day, you know, who are we playing, where are we at? I don't know. He's seeing lights and seeing stars basically. So I think it's something that you always have to reassess patients before, especially after any injury or big hit or anything like that. So always, you can't rule it out just within the first 15 minutes. You got to just continue to monitor patients, and if you definitely suspect there's a concussion there. So, so examination on the field, is the patient awake? Are they moving? Extremities, and that's typically when we first see him or evaluate him. We want to rule out other causes. We always check any neck problems, go through our neuro exam. The main thing we always say, oh, he's probably got a concussion, but do we really know that he doesn't have something else, such as, well, this is how we really examine. So look up, look down, gee, oh, I think you're concussed, and then you guys are like, quit messing around, doc. Does he have a concussion or not? So here's what we don't know that he doesn't have. This is called a subdural hematoma, which is something that can present initially as a concussion, but that's basically a brain bleed, and we don't know that. He's probably got a concussion, but how do we know he doesn't have that? So that's something. Another one is what's called an epidural hematoma. You can see a little, this is on the outside of the dura. It's basically a break in the blood vessel here that causes this bleed, where they can get, people can get hit hard from the side, and that can cause headaches. Obviously, initially they feel bad, and then about, it can happen 12 to 24 hours later, they start to lose consciousness, and so that's why it's something very concerning. We always tell patients with concussions, you got to monitor them for at least the next 24, 48 hours and make sure they're doing okay. And then this is the last one, is intraparenchymal bleed. And this is pretty obvious. Usually they're not conscious at this time. And so that's why we don't know initially when we go to evaluate. That's why we always have to have our athletes lay still, go through our neuro exam, and go from there and make sure they don't have something like this going on. So second impact syndrome, you guys saw those videos. It's basically a shifting of the electrolytes across the neurons. With potassium, the calcium's coming in the cells, and it's an excitable state. And that person needs to heal to allow his neurons and brain cells to recover. Well, if they don't do that, then they get hit again. It doesn't have to be a big hit, and then they can go into that second impact syndrome, which we saw that video for. This doesn't happen if we know our athletes, we keep them out until we can go through our checklist, and that's what Darren's going to talk more about here in a little bit. So our sideline assessments, the nice thing this day and age, we have all sorts of tools for us. We have a little sideline cards that we can give out. We have on our iPhones or Androids, they have little apps for you. You can scroll through. And we always do these little check memory, concentration, our balance testing, and go through, and we can email it to parents, whoever. That's what's nice about today's technology, and make sure that, oh, okay, this person has a concussion. I'm going to show you a few examples here. This is just a pocket tool that it's kind of a little hard to see here, but obviously any red flags, such as are they throwing up, are they they don't have a clue where they're at, their headache's getting a lot worse. Those are all things you're going to send right off to the ER and be evaluated at the emergency room. This just came out with the new consensus. Every 4 years, experts across the world get together and they update a concussion sport consensus. And basically, they just created this. This is an evaluation form for concussions for ages 5 to 12. And you're like, well, why are we worried? 6-year-old kids, they get concussions too? And like, that's pretty concerning, one. But the nice thing is, this is age-appropriate questions for that, and that's something that's you can go to basically Google this, or you can go to Clinical Journal of Sports Medicine. It's a free article that has all these on there. I can get you in touch with that. But this is another thing that, because I've had a few patients, a 9-year-old, one patient to my mind, that he had a concussion, but he was feeling a lot better, but it had only been like 3 days, and his parents were wanting him to get back into practice and playing football again. I'm like, he's only 9. We got to go slow with this, because younger kids, their brains are more susceptible to not recovering as quickly, and plus they're developing. And so we have to really watch them and keep them out, and hopefully prevent them from getting the second impact syndrome. And those are the athletes that are more susceptible to second impact syndrome. So this is the app that's on the iPhone or Android that's really nice. That goes through, and you can ask questions, or it basically walks you through everything, the evaluation, and then you can email it and go from there. So what we do also for a lot of our schools, I know you guys do it here, is the impact testing, and it stands for Immediate Post-Concussive Assessment and Cognitive Testing. It was developed at University of Pittsburgh Medical Center to give objective measurement of concussions. And so it's another tool that we use. We don't put everything on the impact test itself, but it tests memory, concentration, reaction time. It doesn't test balance. That's what we have to do on our exam, but it's another tool we can use to help us manage kids and get them back safely. So it takes about 20 minutes. The ideal is to get a baseline, and then after they're injured, within 48 hours, test them, and then go through the return to play protocol and test them one last time before they're ready to be released. And again, it's only a tool, so someone will, oh, well, my impact's good, but they may be falling off their feet, they can barely walk, but they're doing great on the impact test. So it's not 100%, but it's another tool that we use. I think it's a good one to use. So again, you get a baseline here, and then they get their concussion, and then we basically see them in the first 1 to 3 days, or within 4 days, go ahead and get the second, or the impact test, and then follow them up, and then 7 to 10 days out, if they're doing better, they've completed the return to play protocol, and then test them one more time. So the thing about the nice thing, the impact testing, this is a study that shows athletes, basically they are asymptomatic within 4 days, but their impact over here is their symptoms, and basically they haven't recovered. Their impact score hasn't got back to baseline yet. So even though they're a lot better, I'm ready to go back in, coach, I feel fine at 4 days, they may not be doing their schoolwork as well, their brain's not functioning back to its normal self. That's what I wanted to show on this slide. So a few examples of how we use impact. This is a 17-year-old linebacker. He actually was kicked in the head by his brother, who broke his knee when he got kicked in the head, and he suffered a concussion. So our baseline, you can see everything looks really good. It's a little hard for you guys to see, but he's in the 20th percentile, 27, so not bad. he had a 17 symptom score at baseline. So that's the other question I get. Well, all this time of year especially, oh, my son has allergies, my daughter has allergies. It's just a headache from having allergies. They can go back in. Well, a lot of times, how do you distinguish allergy symptoms versus concussion? What I do is have them do a little bit of exertion, and you can say, well, clearly their headache's getting a lot worse with exertion, and that's how we know that it's more concussion related, and definitely hold them out and go through our exam. Is their balance way off? Well, typically allergies shouldn't affect your balance that much. So not saying that it can't, but when they're drastically can't stand on one leg and they're having problems just balancing, then we know it's more concussion related. So this guy got hit on September 27, 2011 with a concussion, and then we did his impact test. He had a score of 66 symptoms, and you can see his memory composite verbal, which basically words that flash up, was this one of the word that was shown, and he was in less than, I can't read it that well, less than 2 percentile. He was feeling better, so we went ahead and retested him. This is on this third, like a week later or 6 days later, and his symptoms were a lot improved, but he actually did worse on all his visual motor reaction time. And so not only that, but he wasn't completely, he still had a symptom score of 5. The hard thing is you have to determine, he had a baseline with a symptom score of 17, so you have to specifically ask, are these related to the concussion or not? And then 3 days later, he continued to, he finished his return to play protocol, and he went to 0, and everything looked great on here. And so we went ahead and released him to play. He played without any problems. So this is another one. This was a 16-year-old. He was a junior, and this was his second concussion this year. And he had one in the summertime prior to football season. And in football, he suffered this one. And so we were trying to go pretty slow with him. We didn't want him to have any other problems. The thing to notice on here is that he went from 43 for a symptom score, and then he goes to 3. The problem is he still was complaining of the headache right here. So even though they put a 1 out of 6, they'll put a 2 for a headache, but that's their only symptom. It's hard for me to clear somebody to play when they're still complaining of a headache. All of his other scores did pretty well, not back to his baseline. And then here he got back to his baseline. He had one little area that was in the red, but it was fairly close. And so and again, this is just another tool that we use. It's not something that we're going to do, put everything on the impact test, whether they're going to be cleared or not. So it's just an adjunct tool that we help us for return to play to prevent that second impact syndrome. This is the graded return to play that we use, and I think Darren's going to go more into that. But you hold them out and do some light activity once they don't have any symptoms, and each day is a different progression. So someone has a concussion, they're going to be out for about 6 to 7 days. I'm just enabled to complete the return to play protocol. And then we'll usually impact test them afterwards and when they're ready to go back in. So this is another reason what we don't know about concussions. So and this is probably what you guys have heard a lot in the news, is a chronic traumatic encephalopathy, or just chronic sequelae of concussions in general. People are getting headaches that they can't function on a daily basis. They have to sit in dark rooms because light bothers their eyes, and that's what we want to avoid. And so this is another picture here. This is a normal brain tissue of a 65-year-old person, and then this is a 45-year-old retired football player that died of basically an accidental gunshot wound. He played, I think, like 8 years in the NFL. And you can see here, these are all these little tau protein plaques that are evident in his brain. And this is from a 63-year-old boxer that was a world champion boxer. And you can see that something very similar. The problem is we still don't have a direct link from how many blows does it take to get to this point. Does some sort of contact or concussions, brain injury cause this? We don't know yet, but we're seeing more signs of this, and this is from Boston University. They have a grant and studies going on that looks at autopsies of brains for this to try to get more of a direct correlation. But that's the scary thing. We don't know how many hits it takes, and that's why it's always really important that basically we want to keep our kids safe and prevent any long-term consequences from occurring. The other thing is they have some studies that show that that people that die that have these, they never had head injuries. So that's the other thing that they're still trying to work out. But that's what's scary. This gentleman was only 45 here, and he has something that's very similar to someone that was 63 with a boxer, world champion boxer. So in summary, concussions, a brain injury, I think that's something that you got to push parents, kids. It's not just a pulled hamstring or something they can work through. They have to recover. It can be from a direct force or indirect. If they just get hit in the chest, but the force is transmitted through their head, then that can cause concussions as well. Education is key for you guys. Obviously, get them to a licensed healthcare provider. It's the law here in Oklahoma. And have resources available, and when in doubt, sit them out.
Keep in mind as we go through return to play considerations, probably the number one, not only concussion prevention technique, but also concussion recovery technique, is an honest relationship between you and your athletes and them and their coaches. Your athletes need to feel comfortable coming and talking to you. At the end of the day, athletics is huge, but the patient is more of the priority. As long as those two things are kept in line, your kids are going to feel comfortable coming to you. You'll be more effective in managing any injuries or anything that person is dealing with. Concussions are really not so much athletic management as they are whole person management. And those of you that are familiar with healthcare in regards to any type of tissue injury, you're going to find that the more you get into healthcare, the more you're dealing with whole person management rather than just injury-specific management. But let's talk about how to guide that return. Speak specifically about some academic and some athletic considerations. You know, concussions have seemed to become a big problem, especially for those who are participating in some significantly contact and collision-based events. So we'll talk a little bit about recovery. Dr. Glaser spent a lot of time on that. We thank him for that. We'll give you some academic considerations, some athletics and activity, kind of distinguish between the two. Give you some athletic considerations, and I'll give you a case report kind of as a summary of everything we cover. It'll give you an idea how those variables pull into play. Remember the good old days when we played sports and we're never worried if we got concussions? It's interesting how a media-based society and an information-based society has brought this to the forefront so fast. Concussions have always been around in athletics. They're nothing new. What has come to the forefront is greater understanding of exactly what is happening in the brain, what's happening to cause that concussion, and what is necessary for that concussed brain to recover. So let's talk a little bit about recovery. The majority of our patients get better in 7 to 10 days. With rest, they do just fine. The problem that we're seeing, as Dr. Glaser mentioned, is usually the time frame for our kiddos is a lot longer. We have a developing neurological structure that's more pliable, it's more malleable, and it's interesting because usually when it comes to a fracture, when it comes to other types of injuries, our kiddos are the ones that recover the best, and they're the most resilient. However, we're not seeing that yet here. When it comes to concussions, let's say now that you've finished your examination with Dr. Glaser, we have a concussion diagnosed. Where do we need to go from here? Realize a couple of things. Their brain needs rest, their body needs rest. That's no books, that's no exertion, that's no games. Those kids need to know there's no video games, no texting, no apps on your phone. Sit there and relax. And we'll get into that a little bit further. The role of medication in concussion management is basically this. We don't want them on any medication unless it's absolutely necessary to help them sleep. Think about the easiest possible environment for the brain and its tissue. Nothing. Sleep. Rest. That is where the brain can spend the majority of its resources in getting itself improved. So when you start taking things out and start putting energy to, watching a video, putting energy towards homework, putting energy towards calling your buddy on the phone, calling your girlfriend on the phone, Those are other things that are taking away from resources. But in a specific regards to medication, what we want to do is focus on two basic things. Number one, we don't want to use any anti-inflammatory medication. We want that brain to go through its inflammatory response. That word has kind of got a negative connotation in today's society, but that is the first step, if you will. That is, in much like building a building, you have to clear off all the trees, all the scrap, get everything out of the way and make a level base to build from. That is what inflammation does in the body. It is that level base, it is that starting phase. We want it to run its course so we don't place these patients on anti-inflammatory medications. No driving. Obviously, the concussed athlete who may be having dizziness or problems with balance should not be behind the wheel. Give you some signs and symptoms of concussion like Dr. Glaser did, and recognize some worsening signs. If you need handouts on that, you can find that on our website. There's a parent and guardian take-home handout on our website ready to go. Let's talk a little bit about what recovery is not. So many times we focus on what it is and what it is, but a lot of times you can gain a greater perspective if you look at what a concussion recovery is not to understand what a concussion recovery truly should be. We don't set timetables. If you have an athlete that you hear, their doc gives them a note, they never come back to that doc, and the doc's note says 2 weeks, they're good. Patient management is individual. We don't know what that patient is doing at home. We don't know necessarily the full severity of that injury just yet. We've ruled out greater life threats, but severity is determined by longevity of the condition, not just check 1, check 2, and check 3 right now. We want to monitor that patient serially. When you're hearing blanket statements of they'll be good in a week, they'll be good in 2 weeks, if you hear that from one of us, that's because we're making an educated guess based on how we're going to progress that athlete serially with continual follow-ups. But when you hear that one time, 2 weeks, we'll never see him again, that's the one where your red flag ought to go up. Likewise, you don't want to see your patient using medications. You want to have that patient comfortable living their life at rest. If they can't just live their life, go to and fro, do whatever they have to do, and not have a headache, what makes us think they can be successful in an academic nature or be successful in an athletic nature? And we don't want them returning to school with significant unrelenting symptoms that are going to challenge them consistently. What concussion recovery is not? Sitting in front of the TV, watching an exciting movie, playing video games, we've already discussed that, goofing off on the laptop at home, or just shooting around at the basketball gym. That's what concussion recovery is not. And here's kind of the basis behind that. You want to first focus off on rest, and that's physical rest in its nature. We're going to kind of delineate that out. Physical rest basically means no increases in blood pressure. It's much like if you've ever had a bad headache or a bad migraine, the last thing you want to do is get up and be active on it. It would increase the pressure in the brain. It would increase the symptoms and the severity of your headache and whatever you're going through. It doesn't help you get down the road the way you want to go. It takes you backwards. That's what we're looking for. Go home, take a nap, rest, let your brain relax. Cognitive rest is also a very important focus, and this is kind of coming to the forefront of some of the research in the last 5 to 10 years. What we basically want to do is decrease the neurological load on the brain. That's part one. Keep in mind that your brain filters every stimuli that your body is exposed to, whether that be sight, whether that be sound, whether that be smell, whether that be environment, temperature. All those different stimuli come through the brain for processing. So if it's not operating on optimal or full potential, the last thing you want to do is tax it more. Likewise, we want to have a reduction in their critical thinking. We don't want kids having to take a physics exam while they're concussed and having significant symptoms. Think of it like this. There's no research to back what I'm getting ready to tell you. This is just a clinical example that I think should really give you an idea. Let's think about your brain and $10. Let's say that your body has $10 worth of energy to spend in a one-day time period. Let's say it costs $3 for daily life. It costs $3 to do homework. It's money. When you spend it once, it can't be spent again. It's gone. It costs $4 to go to school. It costs $8 for athletics. It's starting to get expensive, isn't it? And let's say full concussion recovery, again, that's not a research-based number, that's just an example. Let's say full concussion recovery requires $20. How can you get there the fastest? Very simple. Start cutting out expenses that you don't need to have. You can spend all $10 every day and get better. I have one patient that we're managing right now. I believe she has a very mild concussion. She sustained it a week and a half ago and didn't tell anybody till the beginning of last week. But she went to school. She was in practice every day. Her symptoms continued to get worse. Her ability to focus and function in school has greatly decreased. But I'm really excited to see how she's going to do in the next few days because she's had the last 3 to 5 off. She finally got what she needed to have. More often than not, here's why we focus on that $10. More than 75% of our concussed patients see great decreases in their symptom reduction. They see actually greater increases in their reaction time. All the things that Dr. Glaser mentioned in the serial examination, we actually see those improve faster, and we actually see them improve better than those that don't rest. And at the end of the day, whether that's the health of the patient or that patient returning back to athletics, that patient returning back to academics, we want to accomplish that as soon as safely possible. So we want to spend all of our resources right where we want them to be spent. We're not there yet. There is no concussion-proof helmet. Helmets were never designed to prevent concussions. Helmets were designed to prevent skull fractures and facial lacerations. Now, granted, there's some great helmets out there, and there are many that do better at absorbing force than others. Helmets have come a long way. But as long as the brain is suspended in fluid where it can move freely, as soon as that skull is bumped, the brain will always move. Regardless of the helmet, if force is transmitted to the head, there will always be a movement of the brain inside the skull. So let's talk about some academic considerations. Should the concussed student athlete be held out of school? Great question. I'll give you this for an answer. How's that? Maybe. Welcome to the forefront of some concussion research. But let me get a little bit closer for you. What we do know is that concussions do affect student athletes in their homework. We do know it's hard to concentrate when we have a headache. Why should we ask someone to do the same? Especially one that's probably more debilitating. We know that cognitive rest is going to be required in some form. We know that neurophysiological testing, the impact testing that we do here at Central States, is very, very helpful. Like Dr. Glaser said, it's a tool. It's not a standalone, but it's another tool. Think of it as sitting an athlete down, sitting a patient down in front of a 20-minute neurocognitive assessment, and if they can't get through that 20-minute segment, what makes us think they can make it through 45 minutes of algebra? It's a very good idea of how that athlete can make a transition. We want to make sure that all our demands on tissue are progressive. It's no different than an ankle sprain. A very severe ankle sprain is probably put in a boot, maybe even a cast. We want that tissue completely rested. Then we go through a progressive weight bearing, then we go progressive balance, progressive running, and then progressive return to play. The key word being progressive. Tissue is tissue in this regard. That's the exact same thing we want to do on the brain. Progressive in academics, progressive in athletics. And keep in mind that not all clinicians are going to acknowledge or address these concerns in the same way. Watch who you're sending your kids to. What we don't know is this line in the sand threshold where a kid must go home and stay home and rest. That's being worked out. We got some pretty good ideas on how to manage that patient. That is being worked out. Why do some do fine and others struggle? Don't know. Probably one of the easiest things to say is we don't know what they're doing at home. We don't know what that patient is doing when they're away from us. Most of you obviously are coaches. You're also probably some sort of educator in the classroom. It's one thing to learn physics one day, but you're expecting that athlete to go home each night and practice it. We're expecting our athlete to do what we tell them to do when we see them, yes, but we're expecting them to go home and practice everything that we've told them to do. If that piece is not there, it'll take a significant amount of time for us to overcome their lack of commitment outside of our setting. Likewise, we sometimes modify school. We can take them from either a half day to a full day with needed rest breaks before we get them to a full day. It's based on the patient. As a general idea from an academic standpoint, keep in mind the value of your team physician, your athletic trainer, and a comprehensive exam. We don't have that magic bullet that says, yes, you have a concussion, yes, you need to go home. However, what we have are very good 7, 8, 9 serial tools that are working together to paint a picture of what our patients need. You don't want your return to play decisions based in a general quiet doctor's office where they're only seen for 5 minutes, there's no neurocognitive testing, there's no exertion testing, and in a nice quiet room their headache's just fine. Get them out and they turn the radio on, it comes right back. Those are two different spectrums. The concussion evaluation and return to play must be a holistic approach. They will require some form of an academic modification, and there's a handout on our website at Central States Orthopedic. That's CSOS ortho.com. You can get that handout available right there. The value of that impact credential clinician cannot be understated. Sometimes as a clinician you kind of feel, you wish there was this answer on the sideline. We come from a society that either said, just tape it, tape an Advil to it. Tape is adhesive paper. Why some think it has miraculous properties, we really don't know. There are some injuries that we can play with because it won't change what's going to happen in the recovery. It won't change what's going to happen in the longevity of that patient's success. This is not one of them. We wish we had this machine, but we don't have it just yet. Let's talk a little bit about athletics and activity, and the reason I kind of want to discuss this, we talk so much about rest, and then we talk about athletics, but I'm going to give you kind of an intermittent step for the minute. Think of it like this. You have a hard Friday night football game. You bring your athletes in first thing on Saturday morning. They are sore. They are stiff. They do not want to move. How are they after that 30 minutes of conditioning? Are they still sore? No. Are they still stiff? No. What happened? You increased blood supply to the tissue that needed it the most. It helped it recover faster. So what you found was a threshold here where you're not in full rest, you're not in full gameplay, but by being active, you helped speed that recovery faster. Same principle here. If you want to define athletics just out of the Webster Dictionary, it's the practice or principles of athletic activities, the weights, the conditioning, the games. But if you think of activity, it's just what it sounds like, just the state of being active. This is going for a walk. This can be exceedingly therapeutic to an athlete who's been inside all day. Likewise, it increases blood flow to the body's tissue. It takes it from a stationary and not being used to its full potential status, not stressing it, but keeping it right there where it can get active and increase its blood flow. So let's talk about some athletic considerations. Before we start activity, we want them very close to asymptomatic status. So I don't mind this patient going for light walks throughout the day, even if they have a very slight headache. We found that a lot of times activity, again, slight walks, maybe a light bike ride, and this is monitored by your healthcare professional. This is monitored by your athletic trainer or your team physician. That can actually be helpful in concussion recovery. And we obviously don't want them on any medications or having any worsening in symptoms in that. But when it comes to athletics, they've got to be asymptomatic at rest. They have to be on no medication, and all their baseline tests have to be back to where they started. So how do we start athletics? No different. It's progression. Everything in rehabilitation is based in progression. That's why you make rehabilitation successful, is because you're progressive. Success in step 1 is going to come before success in step 2. Light aerobic exercise, stationary bikes, long walks, swimming, things that are less than 75%, 70% of the max heart rate. So you're not putting full blood pressure force on the brain and its tissue, but you are putting a little bit to see how it responds. You want to make sure this patient, when they've done this stage, is not complaining of any symptoms. Their neurocognitive exam is just fine. And again, this is something your athletic trainer and your team physician is going to direct. But let's say they pass that stage just fine. Great. We're going to start them on some sport-specific exercise. If you want to know what sport-specific exercise is, think of the phrase one on none. The things that you can do in one plane by yourself. And by one plane, I mean in one general direction. Keep in mind that the way the brain got injured in the first place was due to some shift or torsion force in the skull. The last thing we want to do is start them off in all 3 planes. We want them starting off nice and easy, front to back. Obviously, that's no batting, no heading, anything where they could have risk for contact, anything that could certainly have risk for head contact or a multiplanar movement. They pass that stage. Non-contact training. Again, this is still one on none. Non-contact. We don't want the patient getting hit, so it's not offense versus defense, and it's not one-on-one. Keep in mind that as you're going through these stages, yes, you're progressing in the exertion, but you're also progressing in cognitive demand. That's why the cognitive component's got to come before athletics does. It's one thing to sit there and focus on a mathematic equation. It's something completely different to see 5 guys on a court, analyze their position. Are they in a zone or are they in a man offense? Now what offense am I going to, or now what defense am I going to run to match that? They're doing cognitive thinking on the court, on the field. That's why we want them successful there first before we bring exertion into the play. And then we get them back into return to full competition. We like seeing smiles on kids' faces. That makes a clinician's day. Let me give you a case study to kind of talk to you about some academic and athletic variables. We're going to kind of play with just what you heard, and I'll show you some of the effects of doing such. 17-year-old male quarterback got a concussion September 16th, a couple years ago. He was visibly disoriented, visibly lethargic on the field at the time. His serial assessments continued to show the same, if not slight worsening. We sent him to the emergency room for examination. Clear CT scan at the ER. We restricted into home rest for the weekend. This was a Friday night, so that gives us Saturday and Sunday. School was out on Monday, so our directive to him was stay home Wednesday, or Tuesday and Wednesday. We'll see you on Thursday. We actually examined the patient, or were wanting to examine the patient outside of the school environment for that Thursday follow-up. However, they did not listen to us. Neither the parent nor the athlete, they went to school on Tuesday and Wednesday. Keep in mind, school was out on Monday. So care to guess how I saw him in his state on Thursday? Rather than having 5 days of recovery, he had 2 days of recovery. I think he even went to film on Saturday and then went through a full week of academic load before I saw him. As a result, his headache kept getting worse in class. His teachers were complaining that he wasn't paying attention, and he required frequent breaks going to the nurse's station throughout the day. This is where he was a week after. His symptom score was still at a 36. Keep in mind that ideal symptom score should be 0. His SAC score, a baseline for that, should be 27 to 28. He's operating at a lower neurocognitive capability. BESS is the balance that Dr. Glaser talked to you about. Normal errors should be no more than 3 for the average individual. And then we did his impact test, which looked like this. This is Thursday, the day where he should have had 5 to 6 days of rest, but had 2 days off and then was back in the class. Again, you see the symptom score. As we go through the different variables, not looking to make you an impact credentialed consultant in this presentation, but just look at the discrepancy. Norm for memory composite is 80 to 95. He's hitting 44. This is a straight A student, and he is operating at about half his neurocognitive capabilities. Son, remember how we talked about going home? That's what we'd like you to do. And his dad was 100% on board with that at that time. So now Thursday has come and gone. He's out of school on Friday. The athletic director was completely fine with it. His statement to me was, Darren, how can we do anything different? It's no different that the kid had, went on Monday and got his tonsils taken out. We'll see him back on Thursday. Give me the note. No different. So Monday we follow up with him. Look what happens to his symptom score in a period of 3 days. He goes from a 36, which is a cumulative score of, hey, my headache is a 3, my dizziness is a 4. Well, you add up all those and you get a number. He's now symptom at a 1. His cognitive test is perfect. His balance is baseline. His light walks are being successful. We've started him on homework at his house. We want him to obviously have an academic load where he can take frequent breaks in a comforting environment, not a lot of bright lights, not a lot of noise of the high school hallway, and be successful there before we put him in that high school hallway. Monday and Tuesday of that week, we started picking him up a little bit. I said, son, I want your academic load to increase. He said, what if I run out of homework? I said, find a memory card game. Go online and play Minesweeper on your Microsoft computer. Do something to get yourself thinking. I want you to complete an 8-hour cognitive load at home before you do it at school. Wednesday, symptom score is completely gone. SAC score is completely perfect. Balance score is completely perfect. He's having great success in his walks. He's returning to school. All teachers received an email from the athletic trainer and that return to school handout that we told you about. And as a quarterback, we started him on some non-contact footwork drills. We put a ball in his hand just because it feels good, but he wasn't actually throwing it. Keep in mind that even your injured athletes are still a part of a team, and the more you can keep them involved, even if they're not doing anything in the practice, if they're in the vicinity, it helps in their recovery. Especially in a concussion-based scenario where our patients are more likely to suffer from things like depression. Later in that week, he's completely asymptomatic. He's in his full academic load. He's doing his non-contact quarterback drills. We start picking up his cardio, as mentioned, in our return to play progression. And he is being very successful in his jogging over the weekend. Push-ups, sit-ups. Notice what we're doing there. We're going from 1 plane to 2, and then we added in some rotation. So here's Monday. Here are the teachers' evaluations that they gave back to me. I said, tell me how this patient is doing in class in your own words. One says, I see no areas of deficits noted. One says he's participating at normal level. One says he's performing very well. Here's the one that makes me want to smile. The father says this, so-and-so is acting like himself again. Still trying to figure out why some concussed patients have personality changes. It's interesting as a clinician, a lot of times you don't know these patients until after they've sustained an injury. So you go and you ask these coaches, these parents, how is your son? Is so-and-so acting like so-and-so? And they'll look at you and they'll say, yes. They'll look at you and say, he's not like that. He's very outgoing. He's very boisterous. He makes his presence known. And this is the kid that won't say much sitting in the chair while you're listening to him. That's what you want to see. He's acting like himself again. So here's game week. He's in lighter contact practice, and this is where I got a good laugh and a slight concern out of his football coach. I said, Coach, it's Tuesday and Wednesday's practice. We're planning on him going back to a full competition on Friday. I know he's your quarterback. I need him hit just a little. Quarterbacks usually don't get hit in practice, certainly on game week. That was not just trying to injure a patient. What that was not only speeding his brain up to the pace of a game, before a game, but it's bringing game scenario in a safer environment, and it's building his confidence in his own ability to take a bump and take a hit. You do not want to send an athlete back onto the field who is hesitant. They may be clinically sound, whether that be an ankle sprain, an ACL rehabilitation, or concussion, but you do not want to take that patient and send them back out when you can tell they are not confident in their own abilities. So that was the function of Tuesday and Wednesday. Thursday rolled by. It's pregame day, so it's a very light day. Friday comes, he plays with no competitions. All in all, it took him about 3.5 weeks. Could we theoretically say that it could have been less than that? Maybe. I don't know. But I can tell you that you can see in this one case study the effects of academics on a severe concussion. You can also see the effects of removing them in a severe concussion, and you can see an effective way to progress your athletes, whether it be academic or athletic in nature. If you want some more information, Central States publishes a newsletter, a Sports Medicine Monthly. It's available at no charge on our website. You can go get them at any time. And they are mailed out August through May of each school year. August of 2011 through May of 2012, we spent the whole year, all 10 sessions on concussions. You can wonder, what could you write about so much? We went from everything from the state law to who should be on your management team, how you recognize a concussion, should they go to an ER, what are some field signs of long-term, what we call extended recovery, academic and athletic management, how to actually make a concussion protocol and policy if you would like. And then we summed it up with some different things like discussions on chronic traumatic encephalopathy, some of the supplement discussions that are out there that patients are saying may have some effects in recovery. It is there for you at no charge. If you'd like to sign up, it's obviously there for you at no charge as well. Our goal is just to provide education to those who'd like to have it. We appreciate your time. Thank you for listening, and thank you for taking care of your patients.